Welcome to National Coalition of STD Directors It's Your Call series. Today's call is on congenital syphilis, best practices, prevention, outbreak, identification, and response. Before we get started, let me go through some housekeeping items. First of all, we should be in listen-only mode. Please make sure your phones are on mute. If for some reason one of the facilitators or presenters lose our web connection or voice connection, just hold on and we'll reestablish it. This call is being recorded, and both the recording and the slides are going to be available after the webinar, and we'll send out something where they're going to be at. We try to make these calls very interactive as much as we can. We have over 100 people signed up for this call, so we've had a real lot of interest in this session. Two ways you're going to be able to ask questions and comments. Immediately after every presentation, we hope to be able to have 5 minutes of questions where you can send us a chat question. And at the end of the session, we'll unmute all the phones where we can have actual discussion. So you will be able to ask questions at least through the chat function after each presenter. And you can send questions during your presentation. I'll take a look at the questions and I'll ask the presenters, and then at the end we'll open it up for discussion. So we try to make these calls as interactive as we can with as many people, and they're very peer-led, and hopefully we can have a lot of great discussion. So let me quickly review the agenda. As I said, my name is Charlie Rabins. I'm a technical systems consultant with the National Coalition of STD Directors. Our first talk is going to be by Dr. John Su, who's going to give us an overview of some of the surveillance trends for both primary and secondary syphilis and congenital syphilis, followed by a session by Dr. Julie Stotley from California. California is currently having a couple of outbreaks of congenital syphilis. They're going to talk about sort of what they've done so far. And then followed by a discussion from Lori McManus from Birmingham, Alabama, who's going to talk to us about an outbreak they had several years ago and how they responded and what populations, followed by a presentation from Mark Polizak from Cincinnati, Ohio, talking about an outbreak that they had in Cincinnati and how they responded. And then we're going to open it up for discussions and questions. So hopefully we should have a lot of time for questions and discussion. Before we get started, I want to do a couple of quick polls. First poll is just to give us an idea of who's on the call, where you're from. So if you could quickly indicate where you primarily work at. So just go ahead and mark it, and then we can see the results, and we'll just to give our presenters an idea of where you work.
Hello, Tom Schlenker, San Antonio.
Yeah, thank you. Remember to keep your phone on mute. So we're doing the poll, and looks like about half of the people work at local health departments, about half of the people from state health departments, some others from CDC and other federal agencies and universities. So I think we have a really good mix of people from both local and state health departments, and that's sort of one of our target audiences for these calls is for people working in state and local health departments, so we can share ideas and best practices and what we've learned. The next question we want to ask before we get started is, do you think congenital syphilis is a current or potential problem in your jurisdiction? Okay, please remember to mute your phones. So I think, based on looking at the responses and based on the interest in this call, almost 90% of you think that congenital syphilis either is currently or could potentially be a problem in your jurisdiction. And I think that's one of the lessons is that even though you might not currently have congenital syphilis right now or very many cases, there's always the potential that you could have an outbreak. And hopefully what we're going to be discussing today is some of the ways that you can be ready for, number one, identifying an outbreak as quickly as possible so you can get under control, and what are some of the tools and methods that you can do to help bring it under control. So to help us to get started on sort of where we are with the trends on congenital syphilis, let me turn it over to Dr. John Su from CDC's Division of STD Prevention in the Surveillance Branch to give us an overview of some of the recent syphilis trends. So John, go ahead and get started.
All righty. I'm hoping everybody can hear me. I've unmuted my phone at least. I want to thank everybody for inviting me to speak today about this topic. Primarily, I'm going to be drawing data from past surveillance reports, and I will be speaking about preliminary 2014 data in broad terms. So one of the first things I was hoping to address, and there was supposed to be a poll over here, but one of the issues that really hampers our ability to understand what's happening with congenital syphilis is the long delays in reporting that we have, and a more timely reporting of congenital syphilis case data would be really helpful. In many jurisdictions, we have median times of 3 to 6 months in reporting a case of congenital syphilis. If there's a way we could shrink that down, that'd be really helpful. So, yeah, that's kind of what I was, I thought there was supposed to be a little poll about that, but that's okay. Well, let's go ahead and move forward. So what I'm going to be talking about today, and I'm trying to advance a slide, and it's not moving forward. Charlie, can you give me a hand there? Oh, there we go. So apologize, a little delay on my part. So just to give a brief overview of what I'm going to be discussing today, I'll just briefly make mention about the parallels that we see in trends between primary and secondary or PNS syphilis among females, as well and with congenital syphilis. We'll then focus upon primary and secondary syphilis among females, racial ethnic distributions of rates, as well as some regional trends, and then focus down onto a more local level, MSAs in this case. We'll then shift focus to congenital syphilis, again looking at racial and ethnic distributions of rates, as well as regional trends, followed by state-level trends. We don't publish more local-level data, although I can give some flavor of what that'll be. And then we can briefly wrap with a summary. So as mentioned, congenital syphilis and PNS syphilis among females tend to go hand in hand, which makes sense. You have to have syphilis and be pregnant with it to have congenital syphilis. So typically we see cases of congenital syphilis lag behind rates of female PNS syphilis by about a year or so. And this chart over here demonstrates that where between 2004 and 2008 we see this increase, 2005 to 2008, we see this increase in rates of female PNS syphilis, and we see concurrent increase in cases of congenital syphilis, and we see similar decline in the years following. So, as mentioned, we'll now shift our focus to primary and secondary syphilis among women. Something got cut off in the slide over here, but what this slide is showing are two diagrams taken from two different surveillance reports. The one at the top is from 2009, and the one on the bottom is from 2013. There's a little bit of difference in the way that race ethnicity is reported. In the top, it's by bridged race ethnicity groups from NCHS. On the bottom, it's reported in OMB-defined formats. And because that is, the bottom chart is in OMB format, we didn't get all states in there, 47 states actually. But that captures the vast majority of morbidity. So despite lacking a few states, that chart on the bottom really is reflective of the racial ethnic distributions that we saw in 2013. In both cases, we can see that rates of female PNS are highest among black women, although there's a decrease between 2009 and 2013 among black women. We do see a small increase, well, not a small increase, an increase among American Indian and Alaskan Natives, largely due to recent increases within the Midwest. Just to give an idea of what female PNS syphilis looks like from a racial ethnic perspective. Looking more geographically, what we see is that overall rates of female PNS syphilis did decline during 2009 through 2013. Preliminary data seem to indicate there might be an increase in 2014, and we'll have to wait for the case data before we can speak more definitively. That being said, rates declined during 2009 to 2010. You can see they kind of plateau during 2011 to 2013. During that time, we do see a small continued decrease within the South, but notably there's this small increase in the West, which gains a little speed between 2012 and 2013. Now, these are regional trends, but as you look at a county map that plots rates of primary and secondary syphilis, now this is both male and female, but if you look at rates by county for all PNS syphilis during 2013, you see that even within states, there are specific counties where cases and rates concentrate. So to really understand what's happening with PNS syphilis, you really do need to drill down to a fairly local level. So this slide here presents data, rates of primary and secondary syphilis among selected metropolitan statistical areas in 2013. Now, when I say selected, I mean the whole table from the surveillance report is like 70 some odd MSAs, and so I selected those with 10 or more cases of female PNS syphilis. In 2014, the preliminary data seem to indicate we're seeing the same MSAs, maybe in a different order. But the take-home here really is that female PNS, like other PNS syphilis, concentrates in specific counties. May I ask that folks who are participating please mute your phones?
The whole of the United States.
So based upon some counties, what I can say is that in 2014, on a local level, we do see counties with increases, and probably then MSAs with increases in virtually all census regions of the United States.
I know, right?
So that's female PNS syphilis. We'll now shift our focus to congenital syphilis.
Hey, John, this is Charlie. I'm going to try to mute all the phones, and if for some reason we can't hear you, hit *7 to see if you can get off because we're hearing a lot of interference.
Okay, will do.
The conference has been muted.
Okay, so shifting our focus on to congenital syphilis now. This first slide shows rates and case counts by race ethnicity. I don't show all of them. I simply focus upon white, Hispanic, and black moms. And the reason why I do that is if you take a look at the case counts among these races and ethnicities and compare it to the total, really these three races and ethnicities account for almost 95% of morbidity. So focusing upon these races and ethnicities, what we can see is that over 2009 through 2013, there's this slow decline among black mothers, but during 2012 to 2013, we saw an increase among Hispanic and white mothers. And it appears on preliminary data in 2014 that those trends may continue. Shifting to a geographical focus, during 2009 through 2013, rates overall for congenital syphilis decreased from 2009 through 2012, but they did increase between 2012 to 2013. And preliminary 2014 data suggests there might be another increase in 2014. Now, there is some heterogeneity in those increases. We can see that the Midwest experienced an increase in congenital syphilis between 2009 through 2012, with a decrease in 2013, although overall remaining higher than where things began in 2009. More notably, however, is that between 2012 and 2013, the West experienced an increase in congenital syphilis, much of that from California. And based upon preliminary data in 2014, it appears that we may continue to see increases in congenital syphilis in the West and also within the Northeast. This map over here plots out rates of congenital syphilis by state and in some outlying territories as well. And I just show this to demonstrate that within all regions of the United States, be it the West, the South, the Midwest, even the Northeast, we do see cases of congenital syphilis. So to break that out by some states, over here I'm showing a list of some states with case counts from 2009 through 2013, as well as rates per 100,000 live births during the same time period. And during this first slide, I'm going to show some states that saw increases during this period, and then the following slide, some areas that showed some decreases. And what we can see is that during 2009 through 2013, there were some states in the South and the Midwest outlined in hot pink over here, Louisiana, Florida, Georgia, and other states that had increases in congenital syphilis. And we could see that during 2012 to 2013, there were increases within California. For 2014, we again continue to see some increases in some other states, again in all regions. And it's really, as with female PNS syphilis, it is focused on a local level. Now that said, there were also some states that experienced some decreases during 2009 through 2013. Highlighted in blue here, we can see that Texas and Maryland, as well as Arizona, all experienced some decreases in congenital syphilis during 2009 through 2013. And looks like preliminary data in 2014 suggests that that might continue to be the picture. I will stress, however, that 2014 congenital syphilis data are very preliminary. So I'm very hesitant to say much about congenital syphilis in 2014. So just to briefly summarize what was presented today, female or PNS syphilis among women mostly occurs among black women, although that's been declining in the past recent years, although it may be increasing among Hispanic and white women, and we've seen some recent increases among American Indian and Alaska Native women, much of that due to recent outbreaks within the Midwest. Overall, there's been a decrease in the rate of PNS syphilis among women during 2009 through 2013. It's been fairly stable in recent years, but we've seen recent increases within the West. But that morbidity is very focused in specific counties or cities, metropolitan statistical areas. So really, even within a state, morbidity of PNS syphilis among women can be quite focal. As far as congenital syphilis goes, the highest rates occur among black mothers, but that's been declining slowly in recent years. However, there have been recent increases among Hispanic mothers and white mothers. Overall, there was a decrease in rates of congenital syphilis during 2009 through 2012, with a slight increase during 2012 through 2013. And those recent increases have been occurring mostly within the Midwest as well as the West. That morbidity, based upon the data presented, is focused in specific states, but as with female PNS syphilis, even within a state, it's really going to be driven at the county level. So that's what I've got to present today, and thank you for your attention, and I'll be looking forward to whatever questions people might have.
So thank you, Dr. Sue. If anybody has any questions, if you could use the chat function on the left of your screen and send them a message, and I'll read out the questions. Okay, so while we're waiting for questions, I'm going to go to our next poll question. So one of the things that Dr. Sue sort of alluded to is we sort of had trouble both at the, I would say, the state and national level looking at recent congenital syphilis data. Oftentimes there's real delays in getting cases reported because there's a lot of investigative work and stuff. So one of the questions we wanted to ask is, how quickly is it reasonable, do you think, for programs to submit congenital syphilis case data to either the state or CDC after diagnosis? So if you could give us what you think is feasible. And what we're talking about is preliminary. So it's, it is possible to submit a case to your state or CDC via NETS as a preliminary case, and then later, if you do an investigation and find that it really wasn't a recent case, you can go ahead and change it in NETS. So let's see what people say as far as what's feasible. So I think, encouragingly, over half of you feel that it should be reasonable for most jurisdictions to report a case, at least a preliminary case, not necessarily having the congenital syphilis case report form filled out, but at least a morbidity report and a report via NETS within 30 days. So I think that's kind of helpful to know. Dr. Sue, I have a question for you. How do you think the changes in case definition between 2012 and 2015 affected the case rates?
I think that impact is going to be minimal. The older case definition required that the infant have a reactive treponemal test. The current definition requires a reactive non-treponemal test. Now, if you go to the treatment guidelines, they do specify that if there's suspicion of congenital syphilis within the infant, that a workup should involve drawing non-treponemal titers. The more current congenital syphilis definition is in alignment with those treatment guidelines. But really, in terms of the criteria that rule a case in, so to speak, positive findings on laboratory stains, elevated parameters within CSF, those really haven't changed all that much. And the current definition makes more explicit that either mom could be untreated or inadequately treated, and that's why the case is considered a case, or there might have been suspicious findings in the child independent of anything mom's gone through. And that's always been the case, but it's more explicit now. So I don't really, my opinion is that the case definition really hasn't changed that much, and so I don't think it should have that much impact in terms of rates. Or to put that differently, I don't think that a change in case definition would explain changes in morbidity.
All right, so somebody commented and said that the 2013 case definition removed the possible case.
Okay. Possible case was never an actual definition. In fact, if you go back to the 1996 case definition, which has been in use until this year, there were two kinds of cases: confirmed cases and probable cases. Now, in older report forms, in the back there's an algorithm which also included the terminology presumptive, which is, you may note that presumptive was not part of the case definition. So the recent case definition that was adopted this year didn't really remove any definitions. The definitions still remain a probable case, a confirmed case, a syphilitic stillbirth.
Okay. So based on our poll where over half the people said that they thought it might be feasible to submit preliminary case reports, at least via NETS, do you have any comment as far as what you would like to see people as far as the timeliness of reporting congenital syphilis cases to states and CDC?
Right. Well, given that the polls indicate that the majority of people believe that a report within 60 days is feasible, I would encourage folks to do that. I mean, one thing that I would point out is that case report data can be updated through to closeout, which typically is in late spring of the following year. So to help CDC at least get accurate counts of morbidity, what would be helpful would be to even just reporting preliminary morbidity. Maybe not all the data elements are available or filled, but if there's enough data to indicate that that case meets the case definition, please go ahead and report that preliminary morbidity, and we can update the file as we go. So hopefully by just reporting preliminary morbidity, that can help make reporting more timely and thus give us a better sense at least of morbidity, and then we could do more in-depth analysis down the road.
Okay. And just finally, just the last comment is some of our participants have commented and actually have felt that the change in case definition, they felt like did have a significant impact on case counseling trends. So just, people can take note of that as far as some disagreement on the call.
Okay.
So let me go over to our next speaker, Dr. Julie Stoley from the California Department of Health. And, I think one of the things that we really NCSD really tries to make these calls useful to people. And a lot of the sessions that we do are suggested by our members. And California came to us and said, we're having some increases. What are other people doing to address congenital syphilis? What are some best practices? And that was kind of the impetus of helping to put this webinar together. So please, if you have any ideas for future webinars, please let us know, because we really want to make these webinars timely and helpful to you. So let me turn it over to Julie. Julie, go ahead and get started. And if you're muted, hit *7.
Okay, hi, thank you. And thanks for this opportunity to share what's going on in California. So I'm going to start by briefly reviewing surveillance processes in California, and then describe recent trends in congenital syphilis in our state with a focus on the Southern Central Valley. I will then discuss the California state and local public health response and ongoing questions and challenges that we are facing. I'd like to provide some context regarding STD surveillance and control in California. In California, each of the 61 local health jurisdictions, which include 58 counties and 3 cities, has the authority and responsibility for STD surveillance and control. The California STD program provides some funding, clinical and programmatic expertise, training and technical assistance, and leadership on statewide and cross-jurisdictional projects and policy issues. San Francisco and Los Angeles are funded separately by the CDC. By law, laboratories and medical providers report STD cases to the local health jurisdictions, which report to the state. And most health jurisdictions use CalReady, which stands for California Reportable Disease Information Exchange, a web-based system of reporting. As part of syphilis surveillance in California, the California STD Control Branch conducts regular review of primary and secondary syphilis cases stratified by sex, time, and location. Recently, quarterly review of congenital syphilis trends by local health jurisdiction began as well. Now I'm going to shift to discuss what we are seeing from a surveillance standpoint in California. This slide shows female primary and secondary syphilis and congenital syphilis cases in California from 2009 to 2014. Note that these are cases and not rates. You can see that female PNS syphilis cases showed a sharp increase in 2013, which was accompanied by an increase in congenital syphilis cases. These increases have been sustained through 2014, although our data are still preliminary. The statewide increase in congenital syphilis seen in this table is primarily driven by an increase in cases concentrated in the Southern Central Valley. So here's a map of California. We have over 38 million residents statewide. I suspect that many of you are familiar with the location of San Francisco here and Los Angeles County here. But let me draw your attention to the Southern Central Valley, which consists of Fresno, Kern, Kings, and Tulare counties. Industry in this region is largely agricultural, and income is low relative to much of California. The region is large, over 20,000 square miles, and the population in this area is over 50% Hispanic. This slide shows female primary and secondary syphilis and congenital syphilis cases in the Southern Central Valley from 2009 through 2014. You can see that the scale is different compared to all the cases in California, but the shape of the curves is largely similar, with an increase in both female PNS syphilis cases and congenital syphilis cases over the last 2 years. This slide compares congenital syphilis case counts and rates by California region in 2014. The blue chart on the top left shows the congenital syphilis case count by California area. You can see that the largest number of cases was in the southern Central Valley, followed by Los Angeles and the southern part of California, which consists of several counties including San Diego. But when you look at the chart on the right in red that depicts the congenital syphilis rate by California area in 2014, you can see that the rate in the southern Central Valley is disproportionately high relative to all the other regions in California. Here's the same map of California again with the southern Central Valley highlighted, and we're going to focus in on this region. These images show mapped locations for female primary and secondary syphilis and congenital syphilis cases in the southern Central Valley in 2013 and 2014. On the left, the addresses associated with the female PNS syphilis cases are indicated by purple stars, and on the right, the addresses associated with congenital syphilis cases are indicated by the blue triangles. You can see that the female PNS syphilis cases and congenital syphilis cases are distributed similarly, and that most cases are concentrated in urban areas around Fresno and Bakersfield. State Route 99 runs north-south through most of the Central Valley, including between these two cities. This slide depicts female primary and secondary syphilis cases by year and race ethnicity in the southern Central Valley between 2009 and 2014. There has been a significant increase in cases among Hispanic women and to a lesser extent among white women. Cases among Black women have remained relatively stable over this time period. This shows female PNS syphilis cases by year and age group in the southern Central Valley. In the last year or two, the most significant increases in cases have occurred among women ages 30 to 39 and 25 to 29. But we are also seeing increases in other age groups, including teenagers 15 to 19, young women ages 20 to 24, and in women ages 40 to 49. We are currently in the midst of reviewing congenital syphilis cases in the southern Central Valley over the last 2 years, and preliminary findings have indicated that the majority of the associated maternal cases had late syphilis. Preliminary review of cases reveals that over 1/3 had no prenatal care, and among those that did have prenatal care, it was frequently inadequate. Of the few mothers with early syphilis interviewed, drug use was noted in approximately 1/4 of the interview records, but review of DIS notes suggests that this might be an underestimate of drug use. This review is currently in process. Now I'm going to shift gears to discuss the public health response. We created a multidisciplinary congenital syphilis prevention work group within the California STD Control Branch to think broadly about opportunities to prevent congenital syphilis, from intervention opportunities prior to women becoming pregnant, to opportunities during pregnancy, to preventing clinical disease among babies at the time of delivery. In the pre-pregnancy period, what can we do to optimize screening, diagnosis, and treatment among women at risk? Can we prioritize females of reproductive age for partner services? What about also prioritizing heterosexual males for partner services? Can we partner with family planning colleagues to enhance services for prevention of unwanted pregnancies? During pregnancy, we want to link women to prenatal care and provide comprehensive case management for women who have syphilis while they are pregnant. Timely and adequate treatment must be a priority for providers and for health departments. And at the time of birth, we need to prioritize diagnosing babies at risk for developing clinical symptoms of congenital syphilis by testing mothers who haven't been previously tested or are at risk for having acquired syphilis during pregnancy, and by evaluating and treating the baby. California is working closely with the affected local health jurisdictions, and we are considering a regional meeting with local colleagues to address the rise in congenital syphilis in the southern Central Valley. There are several potential strategies for intervention, including changes in disease investigation and partner services protocols, changes in surveillance systems, clinical and laboratory efforts, policy and other outreach, and primary prevention. For changes in disease investigation procedures and partner services, a revision of the syphilis reactor grid is in process to make all females of childbearing age the highest priority, and to ask DIS to confirm pregnancy status on all women of childbearing age. In addition, we plan to recommend that all pregnant women with syphilis, including late latent syphilis, be interviewed and receive partner services. The current recommendation is for the 3 weekly doses of benzathine to be confirmed among women with late latent syphilis. However, we are revising the protocol to recommend comprehensive case management, including interview and partner services, for all pregnant women with syphilis, including late syphilis. From a surveillance standpoint, local health jurisdictions are doing enhanced case review of cases as they are reported. The state is conducting a larger retrospective review of congenital syphilis state surveillance data over the last several years to identify prevention opportunities for systematic change. We plan to recommend collection of risk data on late syphilis cases among pregnant women, given that most congenital syphilis cases in the southern Central Valley are born to women with late syphilis, and we have inadequate available data on risk factors. We are also working to identify supplemental data elements for collection and CS case investigation, and the state has begun quarterly review of congenital syphilis trends by local health jurisdiction. From a clinical perspective, we will conduct provider trainings on syphilis, focusing on the affected region. Local and state staff may conduct provider visits among providers who serve the population at risk. We are in the process of developing prenatal screening and treatment job aids to disseminate to California providers, and we're thinking about the possibility of piloting syphilis point-of-care testing in a local jail in the affected region. We are also considering what policy changes are available to us, such as working to change the lab reporting requirements such that labs would be mandated to report pregnancy status along with the syphilis test result, or whether the syphilis test was done as part of an obstetric panel. We're encouraging collaboration with potential partners, including local and maternal child health programs, family planning, perinatal hepatitis and HIV programs, drug treatment centers, corrections, and emergency departments. In addition, media advocacy can serve to raise awareness and educate the public, providers, policymakers, and potential partners about congenital syphilis. As one example, there was an article just in November in Kern County that noted the increase in STDs in the region and quoted the March of Dimes about the county's preterm birth rate and rise in syphilis cases. And last, we wanted to mention we're concerned about primary prevention of syphilis in this population. While we don't think that this is going to be the most effective strategy for reducing congenital syphilis, components of primary prevention such as education and information, condom access, linkage to prenatal care, and prevention of unwanted pregnancy are worth considering. We are facing several ongoing questions and challenges right now. There is a lack of information about the underlying drivers of the increase in female primary and secondary syphilis and congenital syphilis cases in the southern Central Valley, and we're going to try to gain additional information by recommending that all pregnant women with late syphilis be interviewed. Another question is, should we make a regional recommendation to conduct third trimester screening and testing at delivery in the affected region? Given that many women have inadequate and intermittent prenatal care, will a third trimester screening recommendation make a difference when there are likely so many factors that contribute to a woman having a baby with congenital syphilis? Alternatively, could we educate providers that they should try to identify and catch these women who are at risk for syphilis at every opportunity, whether it's in the prenatal clinic or emergency department or another healthcare center or the jail or elsewhere, and test and treat them and then link them to prenatal care, much like the public health model in HIV now? Also, how can we prioritize female syphilis cases, especially among pregnant women? We are currently revising the reactor grid and will revise disease investigation protocols to recommend comprehensive case management for pregnant women with syphilis. And last, how can we use our limited resources and shift them to have the greatest impact? We plan to evaluate some of the changes we hope to roll out in the next few months. So thank you for this opportunity to present, and I also wanted to acknowledge several of my colleagues who are working on these efforts, and we welcome any discussion and your input. Thank you.
So thank you, Julie, for that informative presentation. If anybody has any questions, if you could send us a chat question, and we'll ask Julie. So while we're getting started, so here's a question. Is early third trimester testing for syphilis required in California? And if not, how prevalent is that practice?
Early third trimester screening is not required for in California. I don't know how prevalent the practice is.
Yeah, one of the things that I think NCSD is working on is getting a list of what states have third trimester screening requirements, so we can maybe see what's going on with that. And we'll talk a little bit about that later when we talk about TA. Another question was, you talked about a reactor grid. Could you send that to us, and we can send it out to participants on the call?
Yes, definitely we can share that.
Okay. Another question is, can you clarify whether many of the congenital syphilis cases are associated with jails?
We have some information from our review of cases in the last couple of years, but it's limited. I mean, there were just, of the mother, we looked at cases in the Southern Central Valley over the last 2 years, and there were only 10 or 11 mothers with early syphilis who were interviewed, and a couple of them had been incarcerated in the last year. So there were some, but our information is so limited, it's hard to draw any conclusions from that.
Okay. You know, normally we don't do interviews on late cases. Should this be done in high morbidity areas or in areas where outbreaks are occurring?
That's the direction that we're moving in, to try and gain more information and also to make it part of a comprehensive case management among this population. So thinking about the population of pregnant women with syphilis and not thinking as much about if it's primary, secondary, or late latent.
Okay. Can DIS conduct pregnancy tests to confirm pregnancy in case of syphilis?
I don't know the answer to that. I don't know what.
Okay, well, we'll maybe cover that during the discussion. Okay, a couple more questions, and then we're going to move on. How sure are you that you have such a high proportion of congenital syphilis is associated with the late syphilis in mom? Could this be a misclassification?
That's a good question. I think, you know, we have the stage of the mother. You know, it's vetted at different levels and reviewed by different levels in our surveillance section. But I think we feel pretty confident in the stage of the mother.
Okay. All right, so I'm going to move on. We still have a few questions that were asked, and then hopefully at the end we can go back and ask those questions. So let me move to our next poll question. So one of the questions is if you could say which of the tools your program uses to identify or evaluate congenital syphilis, and you can answer more than one. So obviously, you know, like 3/4 of you obviously use the congenital syphilis case report. The CDC case report form is helpful. One of the things we hope to maybe we'll have time to talk a little bit about is that in a lot of jurisdictions you have adverse pregnancy outcome reporting systems that are often housed in the maternal and child health program. Or there are live and fetal death registries, and I think these are often very helpful as far as doing other methods in addition to either identifying cases through reactive serologies or case reports. I know sometimes in Illinois we used to find some cases based on when we would at least monthly try to survey our live birth registry in the ACOR system to see if we identify cases, or sometimes they have ICD-9 codes that you can actually query the data systems for. So, you know, I would encourage a lot of you to check with if you haven't already done this, check with your maternal and child health department, if it's in part of the health department or a separate agency, and see if they're willing to work with you to do some active surveillance on cases. So this is some data that will be interesting for you. I think another interesting thing from the survey is that it looks like 46% of people said that having lab reports with pregnancy status they use. So I think that's another thing. If your report system can be built into that, I know it's not always easy to get your labs to have that data available, but if it is, it could be a useful tool in identifying cases. So we're going to go ahead and move on, and again, hopefully we'll have plenty of time at the end for questions and discussion, turn it over to Lori McManus, who can talk to us about congenital syphilis outbreak that occurred in Jefferson County, Alabama a few years ago. So, Lori?
Yes. First of all, let me say this. I work with the Jefferson County Department of Public Health. I've been around since 1988, so I've kind of seen congenital syphilis come and go. But for those of you who aren't familiar with Jefferson County, it's the most populous county in Alabama. It's home to our largest city, Birmingham, and most of the surrounding suburbs. We're about 660,000 in population, 53% white, 42% African American, and then Asians and Hispanic make up most of the rest of that. And we did experience a rapid rise in primary and secondary syphilis beginning in 2003 that was probably not really recognized until 2004. And while most of the country was seeing an increase in their MSM syphilis during that time, Jefferson County saw a dramatic increase in our heterosexual community. And like the other speakers have just said, the congenital syphilis soon followed that. These are our congenital cases by year. And if you'll notice, our increase started happening in 03 and 04, and then the congenital syphilis case started 05, 06, culminating in 7 cases in 2008. Because we were seeing such a rapid rise in our syphilis at this time, we probably would have overlooked or at least delayed recognition of this accompanying rise in congenital syphilis cases were it not for the fact that we had one DIS that was responsible for all the congenital syphilis reports. It was just a whole lot easier for someone to see a subtle increase because we did have that one person whose only job that was. In a perfect world, I mean, we would think that the prenatal screening would have kind of prevented this, because if women are seeking prenatal care and they're getting the tests done, this shouldn't have happened. We should have found them early on. Alabama actually required screening in the 1st and 3rd trimester, and we were doing that at this time as well. Oops, sorry, can't find the button. So we did look at our, so what's going on? Why were we even getting these increases in congenital syphilis cases? If we looked at the congenital syphilis case reports and our interview record data, this is what we found, that these mothers delivering congenital syphilis babies had limited to no prenatal care. And when I say limited, some of these women, their first prenatal visit was 2 to 3 weeks prior to delivery. They were mostly African American. They mostly admitted to drug use, and most of that drug use was crack cocaine use. These characteristics pretty much mimicked what we were seeing in all of our syphilis, in that most of our cases were occurring in the African American community, and over 80% of them were either directly or indirectly related to drug use, and again, the vast majority of that being crack cocaine use. At that time, less than 20% of our cases were in the MSM population. I think CDC looked at that and go, what the heck are those people in Alabama doing? That's not what everybody else is doing across the country. And at that point, we discovered about 20% of all of our cases from those jail screenings. And the reason for that being is most of those that were being picked up at the jail were being picked up because of drug activity or because of prostitution that may or may not have been directly related to drug use. So what do we do? I mean, what do we do when we see congenital syphilis like this? We weren't going to stop the drug use of those mothers. We weren't going to change their lack of prenatal care seeking behavior. But we could take syphilis out of the equation by effectively treating the population that they were having sex with. So the strategies that we employed to work at our congenital syphilis were also some of the same strategies that we used with our syphilis cases as a whole. And I think we just heard about the provider visits. I mean, that's one of the things that we did. Although we knew that none of our congenital syphilis cases were due to a lack of screening by our providers, we still alerted all of our private providers through personal visits, letting them know that not only is there a problem with an increased amount of syphilis in Jefferson County, but there's also an increased amount of congenital syphilis. We were making sure that they knew who they could contact here at the health department if they saw someone, how to make a referral here if they suspected syphilis. Our disease control director at the time actually also provided information to the medical society here in Jefferson County, again letting them know that not only is there a syphilis problem, but there's an increased congenital syphilis problem. We also utilized a multimedia campaign. We used billboards. We had placards on the buses that were actually going into our high morbidity areas. There were radio spots that were targeted directly to what we were seeing as the characteristics of our syphilis cases. There were news segments, and I owe a lot of that to our public relations point person here. They were very willing and able to do that for us. Certainly, we beefed up our DIS investigation. We added some disease intervention specialists. We had individuals who were responsible for paper that was H'd or the paper that was dispositioned as unable to be located. And we increased our hours. We did targeted screenings. If people are using crack cocaine, well, there's crack houses associated with that, so we were sending our staff into these crack houses to do screenings. Each of our disease intervention specialists have a particular area that they're assigned to, and they were responsible for getting into that area, getting to know where the crack houses were so that we could come in afterwards and provide screening for these individuals. And then we opened it up to, again, the surrounding area. Who are these individuals having sex with? And it's the persons in the surrounding areas, so we set up screening events in the surrounding areas. Some we targeted, wherever the need was, like the barbershop parking lot. I mean, we set up some things there as well. And then we just continued to monitor it, and again, it was kind of easier for us to do that when we had, the one individual that was responsible for that. So what did we feel like worked from what we did? I think one of the main things that worked for us, it was being able to go where the action is. We focused our interventions on that core population, the persons that we knew were the core transmitters. The targeted media that we did, we know that it works. We had our evaluation team here actually did a before and after, and it was amazing at the number of persons who, after seeing the billboards and hearing it on the radio and it kind of being saturated throughout everything that they saw, it increased the numbers of persons that we were able to screen at our clinic. And then having that one designated DIS responsible, I think, was very helpful for us as well, kind of kept us on task. As far as future prevention, I mean, right now our morbidity is mostly MSM. I mean, the pendulum has really swung back to where we're having over 80% of our syphilis is in the MSM population, and then 20% is in our heterosexual population. However, our DIS staff is really mindful of that, so that when we are interviewing MSMs, we are asking always about female partners, because we're ever mindful that the bisexual male is sometimes the most obvious gateway for syphilis to spread from the mostly MSM group back into that heterosexual population to affect our women and the unborn children. So that's what I got.
All right. Well, thanks, Lori. If any of you have questions for Lori, please send it to us on the chat. I have one question already. Did you guys use social media for any targeting at all?
Not during those years. No, I mean we're slowly but surely pulling everybody here into the that is part of the 21st century. We've got to move in that direction, but not in 06 to 09.
Right, and that was really kind of prior to really social media really being proliferated
Correct.
Back then. All right. So next question is, can you talk more about the DIS designated to disposition H investigations? Was there additional follow-up or efforts to locate females, and how productive was it?
Yes, we were very fortunate. At the time, we had 2 disease intervention specialists with a combined experience of over 45 years at that time. They were very well ingrained in our communities. So when there was a DIS who had H'd a piece of paper, it was automatically assigned to them. They reworked it and worked a lot of the angles that others of us would not have had until they were located or we just decided they didn't exist.
Okay.
Yeah.
In addition to the media campaign, did you evaluate any of the other interventions to see if they were working, such as increased screening by providers, better yield from interviewing PNS cases, et cetera?
In a word, no.
Okay.
I mean, I just don't think that was available to us at that time.
All right. Next question, comment. Congratulations on solving this problem. Did you do any field treatment as well as testing?
We did not during that outbreak. We had in previous outbreaks, but we did not during this one.
And field treatment is a little bit difficult with syphilis, especially if you're using bifilin, because you got to be worried about anaphylactic reactions and make sure you have a crash kit and stuff. So that is an issue, I think, for doing field treatment. Okay, last question. How many cases were identified as a result of the media campaign? Were you able to quantify that?
We were not able to quantify that. What we were able to quantify is the increased numbers of persons that actually tested who said, I came here today because I saw billboards or I saw the news spot or heard the radio spot.
Of the media that you used, you were able to quantify which had the best return on investment, like billboards versus bus placards versus?
The bus placards.
And were the bus placards like citywide, or was it targeted for certain neighborhoods?
If I'm not mistaken, they actually, I want to say they were on 8 different buses that were in our high morbidity areas.
Okay. Well, thanks, Lori. And I think it's interesting to hear the different flavors of each outbreak. Is a little bit different, but a lot of the techniques that we use can be used in different jurisdictions. But each outbreak sort of has its own characteristics. So let's go to our next poll question. So, and this kind of came up. We've had some questions about this. Does your STD program have an outbreak response plan that was reviewed during 2014 or within the last year? So this is kind of interesting. Almost 60% of the people are saying that that they didn't have it. They might have an outbreak response plan, but it wasn't reviewed in the last year. And I know one of the lessons that we sort of learned is that you really need to look at your plan every year and update it because things change, staff change, responsibilities change, and that was also a good way of sort of refamiliarizing people with the plan, bringing them up to date. And the other thing that was very helpful for us when we had outbreak plans was, oftentimes there's a lot of things happening besides the outbreak, and to have tools that are already developed like media messages, specific targeted messages to providers that you can hand out. When those tools are pre-developed, it makes it a lot easier to sort of react quickly versus having to stop and develop all that kind of stuff. So, I think one of our recommendations is that you should have an outbreak response plan, and then it should be reviewed and updated at least yearly. So, all right, so I'm going to go to our last speaker, Mark Polizak, is going to talk about an outbreak in Cincinnati, Ohio. So, Mark?
Absolutely. I wanted to talk a little bit about our outbreak. Our outbreak started in 2007, and one of the things that I think Lori talked about this a little bit too, is we originally started off with a small increase in 2007 and 2008, and then in 2009 we had a major increase in our all rate of syphilis, and we began to look closer at Hamilton County, trying to figure out what was going on. At the time, we also had a couple of other smaller outbreaks happening in Ohio. One was happening in Columbus, Ohio. But there really wasn't any connections being made between the Hamilton and Columbus outbreaks at the time. So it was quite disturbing to see this mass increase in cases in Hamilton County and Cincinnati at this period of time. What happened from that point in time is that in 2007, we were mostly seeing an MSM outbreak, and we only had 2 congenital cases that were actually confirmed. And those cases were actually not directly in Cincinnati. They were in smaller communities outside of Cincinnati, which kind of seemed unusual for us. And then between the ending of the MSM outbreak and the beginning of the heterosexual outbreak, the cases of congenital seemed to remain steady. There was never a major increase. And then from 2010 to 2012, our rate rose rapidly. We had 22 cases in 2 years. So we split 11 and 11 in 2010 through 2012. So we saw a real huge increase in congenital syphilis cases. What we found in that 2010 to 2012 boost of cases is that 5 of the mothers were less than 19 years of age, and 21 of the mothers had less than 3 recommended RPRs during prenatal care. 18 of those mothers had less than 8 prenatal visits, so our prenatal visits were down significantly. And the only thing that seemed unusual for us is that when asked about risks, none of the mothers actually claimed knowledge of bisexual partners. So we were still trying to figure out specifically whether or not this outbreak among heterosexuals was even linked to our MSM outbreak. We had some general idea that yes, we were seeing some of the underground network between Columbus and Cincinnati creating some of our cases, but we really couldn't put our finger on it because none of the mothers were actually claiming knowledge of bisexual partners. The Cincinnati outbreak, we learned several things. One of the things that we learned, unfortunately, the hard way is that MSM syphilis quickly transitioned to heterosexual syphilis in a short period of time. One thing about the state of Ohio is that back in 2002, we actually decentralized our program. We used to have a state control program where all of our DIS were state workers. Back in 2002, we actually went with a decentralization program where all of our DIS are now local health department individuals. So one of the things that we had a real difficult time with was having an outbreak response team in place for our state because a lot of the DIS couldn't transition or travel to other areas. Back when we were a centralized program, it was much easier for us to actually move DIS from one area of the state to the other area of the state and bring people in. So the decentralization really caused our outbreak response to be limited. So we had limited success with an outbreak response team in Cincinnati. We had to collaborate significantly with local health department, try and get them to have their DIS available for long periods of time. And some areas just wouldn't even commit to helping other local health departments because of the decentralization problem. One of the things that we found also back in Cincinnati is Cincinnati is divided into like 51 unique neighborhoods, and we had to do a lot of targeting of our messages and interventions. And I think probably early on we began to notice that just generic information about syphilis wasn't working in a lot of the populace. We saw that certain neighborhoods had high prevalence of syphilis, but it seemed as though the messages weren't getting to those individuals. It wasn't until we actually went into those neighborhoods, did targeted messages, did targeted interventions within those neighborhoods that we began to see people trickling in. And then we really had a period of time where females were not a focus because we were dealing with that MSM syphilis outbreak. And then we had our first confirmed congenital case directly in Cincinnati in 2008. And then we began to see congenital cases soar in the years after the MSM focus. We had a PNS rate. We were actually 6th in the U.S. for syphilis with a 24.2 per 100,000. We were up in the top 6 again which was very unusual for us. So Cincinnati was really on fire for a long period of time. We brought in 3 federal teams, 3 CDC teams. The rapid response teams came in 3 times, met with some limited success. Unfortunately, again, because of the short period of time that they were there, it usually would take them a week of their 2-week time to get ready, to get in place, and to start responding to the syphilis cases, and then they would be leaving again in a week. So we did see a couple of the teams have some limited success, but again, by this point in time, we were having so many cases of syphilis just walking into STD clinics in Cincinnati that it became clear that the rapid response teams weren't really helping. So then I think on my final note, we had a period of time where in 2013, our Hamilton County actual syphilis rate dropped to 13.7 per 100,000. And then in 2014, Cincinnati ended the year with only 3 congenital syphilis cases, but unfortunately, again, because of the underground network, Columbus, Ohio has increased to 7 cases of congenital syphilis, ending the year in 2014. So that's some of the things that we saw in Hamilton County.
So thanks, Mark. Questions for Mark? And while we're waiting, I think a couple lessons really stand out a lot from your outbreak, Mark. Is I think one is that how quickly you transition from an MFM situation to a spread into congenital syphilis. So just because most of your cases now are in MSM doesn't mean that you couldn't have a breakout and some patients transmitting to women and then having a quick outbreak. So I think everybody's got to sort of be vigilant. I think the second thing is that in many jurisdictions now, the local health departments are autonomous, and it's important to both have really good working relationships between the state and the local health departments, as well as when outbreaks happen, sometimes you can put together ad hoc sort of work groups, even though the DIS may not be able to work across jurisdiction. I think even partnering with the neighboring jurisdictions where the state or the local health department sponsors a meeting and gets people talking and sharing best practices and lessons can really sort of help out when you're in situations where I think really the model now is that in most places you don't have control and you really have to work with people on the ground and get them to work at it, as well as the fact that even the rapid response teams, I think, thinking that you can come in a week or two and solve the situation, oftentimes you need to be on the ground a lot longer. So I think from all these outbreaks, we've heard some really good lessons. So let me check a couple of the questions. During the outbreak, any idea what strategies worked? Providers increasing screening, jail screening, good partner services?
Well, Dean Collins, being from the state of Ohio, he kind of knows a lot of the things that were happening. But yes, there was an increase in screening. We worked directly with a lot of our providers in the fields to ensure that there was some advanced screening also. We tried to get some work groups working in the Cincinnati area. We still have one that's working currently as our Congenital Outbreak group down in Cincinnati, and they have gone to a lot of the emergency rooms at the hospitals, and they've tried to make people aware of what's actually happening with congenital syphilis, and they do some active investigation at the hospitals to see what's actually taking place with congenital messages and making sure that those messages are consistent. And yes, I do think that good partner services helped for a long period of time.
So what do you attribute the decrease in Hamilton County? Was it a combination of things, one thing?
I think it was a combination of a lot of things. I think it was the local health departments working together, which was for a long period of time. It was difficult because Cincinnati has both a city and a county health department. And because of that, there was a lot of periods of time where the health departments didn't work together or weren't on the same page. We'd have one health department doing one thing and one health department doing another thing. So we'd actually have 2 different messages going out about what was happening with congenital syphilis. So I think once they worked together, it became clear that it was something that was feasible, that we could actually get cases down, that we could bring people into either health department, get them treated, get them tested, and get them back out into the community.
what were your strategies to communicate with women at risk?
Well, I think the Outbreak Response Group in Cincinnati did a great job getting messages to those emergency rooms, to all of those prenatal providers, OB-GYNs, got a lot of messages out to them and tried to get them on the same page with congenital syphilis messages when we started to see that major outbreak between 2008 and 2010.
Okay. Can you clarify what an underground network is?
Sure. We have Cincinnati, Ohio is a very conservative bastion, and we had an underground network of young MSM that transitioned between Cincinnati, Ohio and Columbus, Ohio. Columbus is our centrally located city. It's our capital. It's our state capital. It's also a hub of MSM activity in the state. So there was a huge underground network that I think fueled a lot of the MSM outbreak early in Hamilton County. Because we were getting individuals named back from Columbus. It seemed like there was an underground network from Cincinnati to Columbus and then Cincinnati to Indianapolis. And it was amazing how much our morbidity overlapped between those three cities. It was amazing if we were to drop a map and see where transition lines were. Columbus and Indianapolis' rates were going up almost exactly at the same time that Hamilton County, that Cincinnati's rates were going up.
Did you have any communication or work together with Indiana since it was a different jurisdiction?
Yes, we did. Cincinnati was actively involved with Columbus being in the same state, and Indianapolis was working with us through our OOJ providers. And a lot of our out-of-jurisdiction cases, there was a lot of activity going on in Indiana towards the summer of 2011, where we saw right around southern Ohio, because southern Ohio and southern Indiana border one another. We were seeing about 12 to 14 cases within a 2-week radius right around Cincinnati into southern Indiana. So we were working together very well with the state.
Okay. Can you describe some examples of specific targeting you did by neighborhoods and what did or didn't work in certain groups?
Sure. We did some specific, for example, we have an area in Cincinnati called Over the Rhine, which is a large homeless area. And what we saw in that area is we were pumping in a lot of basic messages about syphilis. And for some reason, we saw a tremendous amount of cases coming out of that area. So what we actually did is we actually partnered with some of the local neighborhood health providers in that area and did some specific homeless awareness campaigns where we actually went in and did homeless awareness. We passed out razors and socks and soap and deodorant, and along with it, we offered syphilis testing at the same time. We did syphilis and HIV testing combined through a health van right directly in that neighborhood. And out of that one specific targeted area, we actually got 4 new positive syphilis cases at the same time we did the homeless awareness.
Okay, great. All right, so we have a few more slides to go through, and then we'll open it up for more general questions. So we have a final poll question. So if you had to think of what your program needs as far as technical assistance or training related to congenital syphilis, indicate which of these, and you can pick more than one, you think would be helpful. And this will help us, both at NCSC, CDC, and the training centers, to sort of figure out where do we need to target some of our interventions related to technical assistance and training. So it's just interesting to look at the responses. Over half the people would like some technical assistance and training related to outbreak response plans. Healthcare provider education, targeted media campaigns really stand out as the big ones. So I think this information is going to be helpful. We'll be able to have these poll results and look at them afterwards, share them with our colleagues at CDC and the training centers, and maybe figure out how we can meet the needs of our members. And so, following along with that, I just wanted to make sure that everybody's aware that there's a lot of different sources for technical assistance. Obviously, the number one source is that if you have any questions related to congenital syphilis or, STD prevention and control in general, we always recommend that you consult with your STD-AAPPS grant program consultant. And if you're not sure who that is or want to talk to somebody, you can talk to Bruce Heath at in the program division at CDC. If it's a policy-related question at CDC, you can refer to Jennifer Ludovic. And at NCSD, you can contact either myself or Dana Cropper-Williams. One of the things that we do that often is helpful, people have questions and they want to know what other states are doing, and we have a weekly email that we send out. And we find that's a good way of asking people what other people are doing and then be able to hook them up with them and share other materials as well as have them on hand. Another thing that we have available is we actually have some staff working at NCSD who do specific state policy and legislation work. So if you're in a jurisdiction, for example, and you were thinking about whether it's EPT or maybe even a third trimester screening law, whether it's a policy or you actually wanted to get some, regulation or legislation, Lucy and Rebecca can provide you assistance. If you're not sure, who to go to, just contact either one of them. They can tell you which of their colleagues handles that. So I think, in addition to CDC and NCSD, there's the training centers. There's other sources of information. So hopefully, we'll be able to help provide people with technical assistance. And again, we are going to make the slides, and there will be a recording of this session. We've got in here information, both email and phone numbers for all of our speakers. So if we weren't able to answer all your questions, and again, we're going to still have some more time after this is over to talk with our speakers. So we have contact information. And so I'm going to quickly go through some of the questions that we didn't get answered, and I'll open them up to the other speakers. And then we'll try to unmute the phones and see if we can have some dialogue in the 10 or 15 minutes that are remaining. The slides are going to be available. Somebody suggested that we do some TA for creating a reactor grid. So hopefully our colleagues at CDC are listening on that one, and we can maybe work together on, or we can share different reactor grids from different jurisdictions. Here's a question, and this is to all the speakers. Do any jurisdictions use the FIMR methodology for congenital syphilis? Louisiana uses it for prenatal HIV cases and is discussing it for congenital syphilis cases. So for any of our speakers, has anybody used that or familiar with it?
Hi, it's John Sue. I know of a number of jurisdictions that have expressed interest in so doing. I don't off the top of my head know what progress has been made there. I did help in modifying some of the tools used within the FEMR HIV method for our application towards congenital syphilis. The last I heard, those tools were available, so I'm going to have to follow up with some colleagues and see where exactly things are. I do know there's a great deal of interest. I'm just not sure how far along it's gotten.
Okay, and if you do find something on it, if you get it to us, we can we have everybody's email who registered for the call, and we can share and get information out, as well as maybe have a link on our website or get it out through the CDC program consultant. So let me see what other questions we had. So while I'm looking, do any of our presenters want to comment on any other of the presentations, any questions they had, or highlight anything that was said from anybody else?
Hi, it's John Sue again. I think I might have missed some of this, but one of the things that stood out to me, I think, was that partner services was helpful in some jurisdictions and less so in others. So the impression I got was that there isn't necessarily a given intervention that's going to work in all contexts, and it seems that there's a bag of tricks, a toolbox, if you will, that has a number of tools, and each jurisdiction will need to find what combination works for them. Is that kind of the impression other people got?
Are other presenters want to comment on that?
Yeah, this is Lori McManus. I definitely think there is a toolbox, because if we had a congenital syphilis outbreak today, I mean, we would go back to the beginning and see why it's occurring before we decided what strategies to use.
And I think the same's true for Ohio here. This is Mark. I would say we're now starting to see a little bit of a congenital syphilis outbreak in Columbus, Ohio, and I think we're looking at a whole different way of trying to approach it this time, I think because of what we learned in Cincinnati.
Yeah, and I think it would be very helpful, for whether it's CDC or we could help put together some sort of a toolbox that has some sample media campaigns targeted, like I think, using the bus placards that were very successful in Birmingham, some of the strategies that Mark used, some things that California's doing. Because I think, again, instead of trying to recreate the wheel every time there's an outbreak, if we could learn and share from a lot of those materials, again, having, provider education kits that sort of spell out, what's the best messages for providers? Is it, symptom recognition? Is it really promoting third trimester screening and follow-up? So I think that's something that I think we need to go back and have some discussion with CDC about where can we be helpful in helping sort of put together some toolkits that then can be readily available, as well as maybe some sample outbreak plans and reactor grids. All right, so we have about 10 minutes. I'm gonna unmute the phones now, and so if people want to ask a question or make a comment, maybe identify yourself and what state you work in, and either make a comment or ask a question to a specific speaker. So let me unmute the phones.
The conference has been muted. The conference has been unmuted.
Hi, Charlie. This is Heidi Bauer in California.
Hi, Heidi.
I have a question for John, actually. Thank you for the presentation on national data. One of the things that struck me about the 2013 CDC surveillance report is that a number of Western states are actually seeing increases in primary and secondary syphilis in females, and in particular, New Mexico, Arizona, Nevada, and Oregon, and of course California. And yet they're not seeing increases in congenital syphilis, and it may be too early or small numbers, but I'm wondering a couple things. One, whether you see this as a harbinger of increased congenital syphilis in those areas, and also whether you see it as an early intervention opportunity before they start seeing congenital syphilis cases to reduce syphilis among heterosexual populations.
Hi, thanks for the question. I would say that any time you've got female primary and secondary syphilis, you have the potential for congenital. So anytime there's female PNS, there's an opportunity to prevent. In addition to that, I think it'd be hard to have a crystal ball and say that if you got female PNS, CNS congenital will follow. But I would say there's definite risk of it, and so it would behoove jurisdictions to be vigilant in those situations and to stay ahead of it.
Other comments related to Heidi's question? I think one question that people struggling with in jurisdictions where you don't have third trimester screening requirements, how useful, for people that do, how useful is it, and do we have any evaluation data to indicate how many cases are identified through third trimester screening? So this is an open question for anybody who wants to comment.
This is Tom Schlenker in San Antonio. We're very interested in that approach. We have 10 to 20 congenital syphilis cases every year, and what we found is that 2/3 of them do get some prenatal care, say from 5 to even as many as 12 visits. And we do have cases of congenital syphilis where the woman has had 11 or 12 visits and many, many opportunities. And we're also thinking that there could be tests done outside of prenatal care, like for example in emergency rooms or places that might see prostitutes or drug users on an emergency basis. How effective that would be, well, we don't know, but we think that in at least 2/3 of our cases, there has been an opportunity, if it had been taken, to screen and test. I'm a little bit concerned that in California, so many of their cases seem to be late syphilis, which of course requires a series of tests, which if diagnosed late in pregnancy, you might not get it done prior to delivery.
This is Julie in California, and yeah, that is definitely something we're seeing when we're reviewing these cases, is many of them are women with late latent syphilis, and they can get one shot in, but they can't get those 3 shots.
Please mute your phones if you're not speaking.
Yes, that is an issue. Or it's late when they start the series and then they miss a couple of days, and then it still ends up being, even if not a clinical case, a case by surveillance as well.
So another good question that we got is, are there any effective interventions to reach at-risk pregnant women to initiate and increase prenatal care visits? And is that something STD programs should be doing?
Hello, this is Christian Guadamaleo from San Antonio Metro Health.
Hi, Chris.
Hi. One thing that we are doing as far as an intervention is that we have a just newly implemented a case management program. And what we do is we actually have a team who will go out and if necessary, do testing, reach those moms who do not have transportation, and that's in order to increase access to health care. A lot of challenges that we reach or that we have is that the people that we're trying to take care of don't have access to cars or funds in order to get to their appointments. And so for an innovative way to do that, we actually look at trying to implement that. We'll also dedicate staff to specifically follow up with at-risk pregnant moms throughout their whole time. So first, second, third trimester, and making sure that they're getting tested as well as treated in order to prevent congenital syphilis. And so that's one of the ways that San Antonio Metro Health is looking at making those improvements to try and reduce those numbers.
Okay, thanks. One of our participants wanted to make sure that everybody knew that the Council of State and Territorial Epidemiologists is working on creating a specific STD outbreak response plan template. So I think that might be, as indicated in our poll question, I think that will be helpful to a lot of jurisdictions. However, I think in the interim, I think NCSD would be happy to work as a vehicle to help share if people have outbreak response plans that they want to say that, we think this has been a helpful plan and give it to us, and other people want to, use that as a template. We'd be happy to share plans as well as, again, consult with your CDC program consultant who can maybe hook you up with some examples of some good plans from some of their other project areas. So we have about 2 more minutes before we're going to conclude. Any more additional questions or comments?
Hi, this is Amanda from South Dakota.
Okay.
Can anyone hear me?
Yeah, we can hear you, Amanda.
We're one of those states in the Midwest that has been seeing an increase in PNS in heterosexual women, and then also we've now had a small handful of congenital cases. I'm just curious as to if any other state, we've had a fetal death that doesn't meet the CDC requirements for reporting, but it's a pretty suspicious fetal death with both the mother and father being positive for syphilis. Does any other state use any of those suspect or likely, I guess, fetal deaths as far as any of their outreach and education for providers and for the community? Do you mention it at all, or do you not even?
Does somebody want to address? Again, if people can keep their phones muted if you're not talking. Does anybody have a comment?
Oh, okay. Okay. No, okay. I'll walk with you now because I had to go upstairs.
All right. Can you please mute your phone? Thank you. So anybody want to comment on Amanda's question? I know it's kind of hard to hear with all the background noise. All right. And if anybody does, they can email me and I'll get the answer to Amanda. The last sort of question or comment is we'll have concluding remarks is somebody want to know is any program considering using the rapid syphilis health check test with high risk women? Has anybody talked about doing that?
South Dakota is talking about that.
Okay,
the
so
state
South
of
Dakota is Ohio.
Ohio is going to be doing that as well.
Question? New Mexico.
Florida.
New Mexico is also going to be.
Okay, let me repeat the question.
Houston is in Houston, city of Houston.
Okay. So the question was, are there any programs considering using the new rapid syphilis health check test with high-risk women? And so I think there were a number of states that indicated they were. I would say, if you're interested in pursuing that, we can put that in our NCSD weekly email blurb and ask for, what states are considering it. And then if it would be helpful, we can help sponsor a call where the jurisdictions can, sort of get together and maybe talk about how they're going to implement it, how they're going to evaluate it, so we can sort of share best practices and learn from each other. So, so let me just wrap it up. First of all, thanks. I want to thank all our speakers for the great presentations. I think it really gave us a flavor of some of the commonalities of, best practices, lessons learned, as well as some of the unique features that each outbreak has. NCSD usually does these calls every other month. They're really member-driven, so if you have any suggestions or topics you would like us to do, please make sure that you send, either send me or Dana Crawford-Williams an email, and we'll be happy to help sponsor a call, or you can talk to your CDC consultant and ask them about what training is available. At the conclusion of this session, you're going to be given a link to go to a SurveyMonkey, really brief 4 or 5 question survey so we can evaluate our calls and make sure that we're continually improving them and making them helpful to people. So on behalf of NCSD, I want to thank everybody both our speakers and participants, for I think was a very informative call, and we'll talk to you on the next call. Thank you.